us now to talk about your health is Dr. Gavin Henry, Medical Director of the Tate Cancer Center at the University of Maryland, Baltimore Washington Medical Center. Doctor, thank you so much for joining us.
Oh, thank you for having me.
November is Lung Cancer Awareness Month. Remains the number one cancer killer of Americans.
Yeah. Currently, right now, lung cancer is still the number one cause for cancer deaths. Is second in regards to incidence in the United States, breast being number one and lung cancer being number two. But in regards to lung cancer deaths, lung cancer is number one, with approximately about 240,000 deaths per year.
Who is most at risk?
Mainly smokers, long-term smokers. Those who may have also had secondhand smoke are at risk. Maybe if you had some history or exposure to asbestos as a possibility, because that can also increase the risk. Obviously, there's thoughts about radon gas, but mainly smokers are what we normally see, usually engaging about 90% of most of our patients.
Good news is, I guess, you see far fewer people smoking these days. Smoking tobacco at least, maybe smoking other stuff. Has that led to a decrease maybe in cases of lung cancer, or too soon?
Yes. Overall, we've definitely have seen a decrease in the lung cancer deaths, but it's still pretty high. We've definitely seen the trend down over the last 5 to 10 years in regards to the deaths, but it's still pretty high and still number one. But and that's mainly because less people are smoking overall in general.
So in addition to being the chair of thoracic surgery, you also lead the lung cancer screening program. Tell us about that.
Yeah, the lung cancer screening program is pretty important to what we've been doing at the Tate Cancer Center, and pretty important for most thoracic surgeons and pulmonologists that are out there, because we're still at we're at a crossroads. We have a high death rate from lung cancer, but yet from a lung screening standpoint, only approximately about 6 to 7% of people who need to be screened actually get screened. When you compare that to breast cancer, maybe it's around 75%, colon cancer, maybe around 70-75% of people who get screened. Lung cancer is only about 6%, and that's very, very low. And so we know that lung cancer screening is important. So because it's important for early detection. And so I think that that's been our push, and I think that's been a lot of push for a lot of healthcare providers.
And you know it better than anybody as the surgeon operating on people. What's the difference in terms of the procedure and the outlook for somebody who is coming in as an early stage patient versus a late stage?
Yeah, and so when most patients get diagnosed with lung cancer, most patients are late stage, and we can say anywhere between 60 to 70% are considered late stage. And at that point, it's hard to cure. And so that's why that screening is important, so we can detect patients very early. Whereas currently right now, maybe about 25 to 26% of patients get picked up early. And our ability to pick patients up early means that we can get them to the operating room or other means in regards to the possibility of cure. So our cure rate becomes higher when we pick them up early, and the survival becomes higher. Whereas if you're picked up late, the numbers are very, very dim.
What does the screening entail? Can it be done with a simple chest X-ray? And who qualifies for it?
Well, most screening currently entails a low-dose CT scan. And it takes roughly about 5 or 10 minutes of total time. You have to get on the bed and you kind of go through the donut, not a tube like an MRI, a donut. It literally takes about 5 minutes. And it is a low dose, so it's lower dose than a normal CT scan. And we'll say it's probably equivalent to maybe 4 chest X-rays. So the technology obviously has improved over the last couple of decades in regards to the amount of radiation that patients get, because that's always a question. But it's a very simple process, doesn't hurt. You just lay in a bed and maybe you have to hold your breath for 15, 20 seconds at any one point in time. And about 5 minutes, 5 to 10 minutes at most, typically. So it's a relatively easy test.
who should get that? And the other thing people may wonder about is my insurance going to cover this?
Yeah. So currently there's been new guidelines that have come out from 21, but most recently the American Cancer Society put out their guidelines, and they have expanded the guidelines. Currently, if you're between the ages of 50 to 80, and if you're a current smoker or have smoked for more than what we call 20 pack year history, so if you had to smoke a pack a day for more than 20 years, that's considered 20 pack year history. You fit that screening guidelines. More importantly, there's no limitation on when you stop smoking. It used to be a limitation. If you stop smoking within 15 years, that was a limitation, but they have not limited that. And so the new screening guidelines has helped a lot. It's probably opened up another 5 million people who probably should be screened. And we're hoping that that starts the door of increasing that percentage.
You know, I did read that Maryland as a state lags the nation in the number of people getting screened here. Yeah. I don't know what would account for that, but how can we address it? How can we make it more available, more convenient for people?
Yeah, it's Maryland. I think we're about 2.5% of people who should be screened actually get screening, and that's pretty low. Like I said before, you're roughly at 6%, and that's still nationally pretty low. And maybe the best state may be at 12%. So nationally, we're still relatively low. But I think education is probably the biggest thing. Just getting the word out, especially to their primary care doctors, different systems. Educating the community, I think, is important at their local community, but that has to continue. I think that right now we're not doing as good of a job as we probably should be. I think part of what we also battle too is that some people who smoke and are in that who fit that criteria, they have a little bit of stigma, and so a lot of times they don't want to get screened. You know, they smoked and but we kind of battled a little bit of that. But education is probably the biggest thing.
And I'm sure people worry about getting bad news. I mean, what happens if a scan finds something suspicious? What happens next?
Yeah, and a lot of it depends on what they find. And sometimes they may find what we call a lung nodule. That could be the beginning of cancer, or it could just be totally benign. And most of the time it is. But if you have that history of smoking, well, if there's something there, usually what it means is you typically may end up having to follow up with a pulmonologist or a chest surgeon, so you can really assess the CAT scan to see does it look riskier? Does it look like something that we should go afterwards in regards to biopsying or just getting more information about it? And sometimes we may just follow it with another CAT scan, and a few months later, if our suspicion is low. So there's a whole bunch of other things that we kind of look at in regards to what's the next step. So it can be many things depending upon the suspicion. It may be a low index of suspicion. Something may be very, very, they're very tiny, and we may say, let's get another scan just to watch it. But there may be times when this looks concerning, and then we may get further testing.
With lung cancer, do you see disparities in outcomes among different groups in society? We see health disparities with minority groups, with also COVID, all sorts of things for a variety of reasons, including access and cost. Is it an issue here? Yeah,
it is an issue, and just like with COVID and some of the other medical issues, it is an issue with low income and also minority groups, and they are picked up later. So usually when they're diagnosed, they have a higher stage of diagnosis, and also they also don't get screened as much as the regular population. So it is an issue, and that also is one of the reasons why they increased the aging, because before it was 55 to 80, now it's 50 years old. So we know that in minorities, the age detection for lung cancer is slightly younger. And also less pack year history of smoking. So that's why they've also changed that, so you can hopefully pick up those others from a screening standpoint.
Well, tell us about the surgeries that you perform, and maybe how often it's curative, what you can do for people, and a little about the technology and how that's changed.
Yeah, usually when a patient kind of comes to me, I always say it's sort of a black cloud with a silver lining. No one wants to have a diagnosis of a lung cancer, but the silver lining is usually if they come to me, we always say it's ability to possibility of cure, because usually that means you're getting picked up in an early stage. And yes, surgery is scary, and at that point in time, we usually evaluate patients very carefully, making sure they can tolerate surgery and recover. Now, most surgeons are doing our resections minimally invasive with small incisions. I do mine typically robotically, as with a lot of surgeons throughout the country. So it allows us to do keyhole surgery and have a quicker recovery, and patients can get out of hospital in about a 2 to 3 day stay and can recover and have a full recovery within 3 to 4 weeks. And so that has improved significantly when you compare it to 2 decades, 3 decades ago, where we make bigger incisions and the surgery is a lot tougher and so forth. And so that's why we want to push the envelope in lung screening, because we know that we can get patients in, get them out, and get them back to their way of life.
How often are other forms of treatment involved? Radiation, medical therapy, and so forth?
Yeah. So we look at medical therapy such as chemo, or some people immunotherapy, and radiation has another tool. So surgery is also a tool too. So we have all these tools in our tool belts. And the question is which tool can we use for certain cancers? And it really kind of depends upon the staging. When they get diagnosed, and also to the patient's health. Can they tolerate surgery? So we all kind of come together typically in most places, and we have discussions with the other specialties, and typically, what is the best treatment for this patient? Now, obviously, there's some generality to it for most part, but for most part, we kind of communicate. So we have this one-stop shopping for most patients, and we always, hey, what's the best one? Radiation, chemo, or immuno, or surgery. Everyone gets to get customized in regards to their treatment.
Does family history play a role here? Is there any genetic hereditary factor, or is smoking the big one?
That's it's a great question, and that's one of the more common questions that patients do ask me. And usually I would say smoking is usually the number one. I'm pretty sure somewhere along the way there must be some genetics involved, because you can have one patient smoke for 50 years and not get totally healthy, and then you have one patient who smokes for 10 years and they'll have lung cancer. So I'm pretty sure there must be some genetics involved in that one. But in regards to just, am I going to pass it down to my daughter? I'm going to pass it down to my son? We haven't really seen that. And for most part, it is smoking is usually the biggest risk.
I was thinking about what else might go into the decision for a smoker who's heard about the availability of screenings, hasn't done it. You mentioned possible stigma. Mm-hmm. Nobody wants to get bad news and start down that road. But the other thing is, they might say, I feel fine. I have no symptoms. Does that mean you're okay?
Yeah, we always say you're always fine until when you're not fine. And that's a problem with not only lung cancer, it has with most cancers, is usually you're not symptomatic. But when you do have symptoms, usually at that time it's usually a later stage, and you don't want to be discovered then. And so that's why we're pushing screening, both for all different types of cancers, and especially for lung, because you want to get picked up when you don't have symptoms, because that's the best chance you can take care of this problem. But it is a stigma, and it's like and we can pick up other things too, and that's the other thing with CT scans, is you don't only look at the lungs, there are other things you may incidentally pick up that are important for patients' care.
Dr. Gavin Henry is head of the lung cancer screening program at the Tate Cancer Center at the University of Maryland, Baltimore, Washington Medical Center. Doctor, thank you for being with us.
Thank you for having me.